Good afternoon, everybody. It's just gone past 12 o'clock, so we'll get started. Good afternoon. Thank you very much for joining us, and welcome to EMIS Live, the new normal. In this session today, we will discuss the Somerset end-of-life planning. I'm delighted to introduce two people joining us today. It's Dr. Justin Harrington, who is the CCIO at Somerset CCG, and Richard Greaves, the Head of Digital Transformation, also at Somerset CCG. Just a reminder, we've had a fantastic turnout today, so you will remain on mute for the duration of the session. Please feel free to ask questions. If you move your mouse and toggle, you should be able to see in the top right corner, I think there's a question and answer box. Simply type your question in there, and we've got a team on the other end of the line who will be able to try and assist and answer those questions as we go through. And clearly any we don't get to answer, we will make sure we follow up afterwards. The session will be recorded, so we'll make sure we share it out after the event for anyone who either joins late or if you wish to share it further from there. So without further delay, I will hand over to Dr. Justin Harrington, who will begin the session. Thank you.
Thank you very much. Good afternoon, everybody. We'll start the session. I'm a GP in Somerset. I've been a GP for 30 years, and really since I started in practice in 1990, I had an interest in computing. And I've been lucky enough to work with Somerset CCG for a number of years now in that CCIO role. I've also got Richard Greaves with me, who's worked closely with me on this particular programme, and we also have Sean O'Mahony from Black Pear, who's in on the call. So without further ado, we'll start talking about our EPaCCS program that we introduced. So a number of people aren't fully aware of what EPAC stands for, so I do apologise if I'm teaching my grandmother to suck eggs, but it stands for Electronic Palliative Care Coordination System. In Somerset, we've had a EPAC system for many years, going back to about 2012. It was something of a clunky system, and it was rather painstaking. It sat apart from the GP system. It had 12 mandatory fields that had to be filled in. If you got part way through creating a new record and didn't have the information for one of those fields, you couldn't partially save it. You had to abandon the whole procedure. Equally, if you didn't put the details in the same way, such as ST for street and then street in full, it was quite easy to create duplicate records. And it could take 10 or 15 minutes to create one of these. And it was recognised by our GP end-of-life lead at the time, Chris Absalom, that this was having a significant impact on people using the system. So he came to myself and Richard and challenged us, gave us a clinical challenge. He said, surely in this day and age, we must be able to come up with something that is better for clinicians and is easier to use. So the principle has always been that this is being created by Somerset clinicians for Somerset clinicians, not just GPs, but that's been a product of close working with our cider technology partner Black Pear. The aim has been from the outset to have one county-wide record for each patient and for it to be accessible in any care setting. So in taking this forward, we decided that the key steps to improvement were that clinical leadership. So I was involved with Dr. Absalom, but the principles were that we would have it digitally enabled to deliver care, and that's come through working with Black Pear. In terms of our standards, we looked at the SCCI 1580 palliative care data sets and ensured that we had all the mandated fields available in this record. Our aim was to get something that was faster, efficient, more intelligent, and through the work that Black Pear are able to do, maintained a persistent connection with the GP record. We also wanted it to be accessible to view, create or update in any care setting, because one of the things that I think we all understand is that the EPaCCS care plan is a living document. Things change and the patient's care needs can change within days. So it needs to be something that can be updated readily. We identified that Black Pear were able to do some clever things with clinical systems and to meet those conditions that we'd set above, and that they'd already done some of this work in other areas of the country and already had something which seemed to very much fit the bill. We work very closely with our GP colleagues, so it was important to us to get the support of the LMC, and I understand that that might vary around the country, but certainly in our area they're keen to be involved in projects which lead to improved patient care, and they have an IT lead. So we specifically recruited a number of the LMC GPs to help us trial it out and get a sense of reality. And we were keen to use every opportunity and every contact to demo it. I don't think that you can do enough of the groundwork of talking about it and showing it to people, giving every opportunity to get others to see what you can do. But it's also important to listen to the feedback, and despite sometimes some initial negativity, to keep going. So in doing all this work, we literally thought about anyone who might be involved in the care of a patient who's for palliative care. So our stakeholders include Black Pear Software, all the 65 GP practices in Somerset, St Margaret's, Dorothy House and Western Hospices, who are the hospices operating in Somerset. We have an end-of-life care coordination service that's provided by our community services provider organisation. We also have involved the district nurses, and one of our district hospitals, Yeovil District Hospital, have a palliative specialist palliative care team. And we also wanted to involve the Devon Doctors 111 and out of hours services, as we recognise that as the out of hours GP service, they're often involved with patients' conditions that change or may need some sort of intervention, particularly over weekends when patients may not have access to their GP for over 48 hours. So our final product was that we came up with our Somerset EPaCCS in a form where all bar 3 mandatory fields for giving the basic data set are populated from the GP record. In Somerset, we're very lucky in that we have all the practices operating on one clinical system, EMIS. So that had made things much easier for us. And as a summary, in just over a year, we've created over 2,100 records. And to put that in context, we exceeded in 12 months the number of records we had collected over a period of 12 years with the previous system. And one of the most useful things is that changes made to that care plan are written back to the GP record. So the 3 mandatory fields are to comply with data protection and GDPR. There is a requirement to inform the patient. And we understood that with the changes in GDPR, there was no need to seek consent. For the purposes of direct care, it's sufficient to inform the patient at the time that you are creating the record, or to inform the patient if perhaps you're doing something like a home visit and then go away to create the record. There's a requirement to record the primary diagnosis, and then finally to indicate what the CPR status is for that particular patient at that point in time. So what I would propose that we do now is that we give a demonstration of this system. So I'm going to drop out of the slide set and I'm going to start up my clinical system. And this is just to demonstrate that we have here a situation where I have a dummy patient who unfortunately has a lethal midline granuloma. And yes, I did have a patient with this. Having decided that I want to now create a palliative care record, I click on to my Pyrus Apps portal, which is the Black Pear software. This automatically integrates with the clinical system and pulls through the patient's details, as you can see in the top left-hand corner. In this instance, there is no EPaCCS record indicated by the 0, so I'm going to create a new record. As we indicated earlier, I have to put that the patient has been informed. It automatically takes me on to the second piece of mandatory work that I have to do, which is to select the primary end-of-life care diagnosis. Now, the system's clever enough to pull through the active problems from EMIS, and it will present those to me if I click on the drop-down list. So I can click the lethal midline granuloma and press save, but equally I could type in free text if I wanted to. And finally, I go on to record the CPR decision, and it looks as if that's already been populated. There's that's an interesting demonstration that it's already pulled that through from EMIS, so I hadn't spotted that that dummy patient has that already recorded. And that's it. I could, at this point, just click save, and from there, write that record, save it permanently, and write a copy back to the GP system. And it literally is as quick as that. We can usually do that basic record creation in about 60 seconds. Just want to show you that that's a demonstration of how quickly you can initiate a record. So we missed out some of the details, so I'll call that record back up. But in that record, there's a whole load of other information. So I was simply presented with those mandatory fields, but if I'd stayed in the record, I could have looked and seen that there was other information available. So the patient's details are pulled through automatically in terms of their demographic record. The GP's details are saved as well automatically. That's in there. And then moving further down, there's also information that's being captured around medication and allergies. These have all been pulled through automatically from the EMIS system. As I say, there's also the information about the treatment escalation plan that could be filled out and their DNAR status. There's also a clinical summary and I see that some Scally has put on an unusual diagnosis of late syphilis, but more realistically there's type 2 diabetes and a mammography request recorded on the active problem list. There's also the opportunity to record more detailed information if you want to, and it's possible to upload documents such as advance statements, power of attorney, advance care plans as PDF or Word attachments. It's also anticipated that other information will be filled out in due course. So not everything needs to be filled out immediately, or indeed will be relevant. So it may be that there is no need to require any information about a disability if the patient doesn't have one. And it may be that carers information again will be filled out by somebody else in due course. If I go back to the active session, cancel that. If I look back in the GP record, when I reload, I can see here that the patient's record has been updated with some codes, preferred place of death, that they're on the end of life register, and that they have a PDF attachment as well as a belt and braces option, which contains a summary just in case someone doesn't have access to the EPAC system itself, but has access to something like EMIS Viewer. So there's a link there. The slides will be going out later. So there is a link to a video that we put out on YouTube as well, where you can see that demonstration again if you want to. So we thought that was pretty good and a good start, but we weren't sure whether that was enough, and we thought, no, we could do better. All the changes made are tracked in the system audit trail. So it's possible to see exactly who's been involved, who's changed the patient record or added new information. We thought we could do better still. So we added further functionality. Tailored notifications of changes can be sent by secure email, which means that you can identify certain fields that, if they're changed, will trigger an email being sent to, for example, key individuals, which in this instance would be the GP. So should a hospice nurse have a conversation with a patient who then decides that they no longer wish to be resuscitated, that hospice nurse could, for example, change the DNAR status, and you could have the system configured so that an email notification is sent to the GP to this effect. Even then, we didn't think that that was enough and that we could make further improvements. So the GP record is sent an active copy of the care plan, which automatically embeds in the consultation screen. As you saw there, that PDF document is available and it will write codes. And this was far superior to our previous system, which had no links at all and was a completely separate standalone system. We still weren't happy with that. We We're also able to update with the relevant SNOMED codes. They were READ codes originally, but obviously we've moved over to SNOMED code equivalents. And so those codes are recorded. So when a new record is created, it will indicate that to the system that a code needs to be written back, which is implanted into EMIS, saying that the patient has an end-of-life care plan and that they're on the palliative care register. And this is very useful because it helps with QOF around palliative care. Still not happy. We thought we could do better. The system is clever enough to detect that when someone's accessing the record, there may have been changes made in the GP system, so that medication may have been stopped, new medication may have been started. So when someone accesses that black pair record, it automatically updates with any changes that have been made in the GP system with certain fields, such as allergies and medication. Still wanting some more improvements and some benefits, we were able to configure it so that it will be viewable via the 111 and out of hours services in their own native system. So they do not need to log on to the system or link into the system in any way. So it's integrated with their records. As a further enhancement, we decided that EPaCCS will be part of the Somerset Health and Care Shared Record Service when it launches in autumn 2020. And this has become perhaps quite relevant in light of the changes that have occurred to the way we work with the COVID crisis. Still not enough. Clinicians can enrich the EPaCCS with the following, as you saw in that section: lasting power of attorney, advanced care plans, any treatment escalation plan that you might have, and details of just in case medication. In fact, any document can be uploaded as long as it's in that PDF or Word document format. So we were fairly pleased with that, and one enhancement that we perhaps haven't recorded in the slides is that with the 111 and out of hours system, not only is it viewable in their native record there, but actually a flag is raised so that they can see when a patient has an EPaCCS record, and the call handler gets a notification of that, and they can then pass that call on to a clinician more easily and indicate that there's something for them to look at. So with all those improvements in mind, we actually have created 10 improvements over the previous EPaCCS system. And I won't read them all out there, but they're what we've been through in the presentation itself. So we felt that that was a significant enhancement going forward. Finally, I would say that we did do a lot of work in going out and engaging with all those stakeholders. So we've had a lot of conversations with the hospice and the hospice nursing teams, the district nurses, and we've been out and met with the various district nurse teams attached to the federations and more recently the PCNs, as well as going out and talking to the end of life care coordination service, as well as doing presentations to all the GPs in a number of settings and trying to encourage them to use the system. And I think that can't be underestimated in terms of promoting the fact that for this system to work, as a shared care record, everyone not only needs to be viewing it, but actually just inputting anything that may be relevant after they've seen the patient, even if it only is 1 or 2 words. That can make all the difference. And what we've tried to do, certainly for GPs, is make it as easily accessible in terms of updating the record as it is to create one. So similarly, it only takes about 60 seconds if a GP's been out to see a patient or started some just in case medication to update that record. And I think that's probably a good point to pass over to see if there are any questions.
Justin, thank you very much for giving us a fantastic run through the end of life program there. Clearly, you've got a team that don't wish to rest on their laurels, always pushing forwards, always trying to seek how they can explore getting best use out of the product, which is fantastic. There have been some questions coming through on the right hand side bar there, and Richard has been doing a fine job answering those questions as we go along. And as mentioned, this will be recorded, or has been recorded. All of these questions will also be provided back to participants as well. So all the questions, any unanswered questions, will be sent through as well. Finally, a sort of a thank you very much for everyone for joining this afternoon. There are a number of more sessions through EMIS Live, the new normal, so by all means sign up for any others that you wish to do so. But once again, from myself and everyone else, thank you very much, and we look forward to speaking again soon.